Diversity and Inclusion Committee. Today's meeting is officially called to order. Next on the agenda, I would like to propose a motion to adopt the minutes of the Equity, Diversity, and Inclusion Committee meeting held on April 8, 2025. Dr. Katz?
Yes.
Jackie Rowe Adams?
Yes.
Vanessa Rodriguez?
Yes.
And myself, yes. Next is a diversity and inclusion update from Yvette Villanueva.
Thank you. I am here on behalf of Ibelis Mendez Justiano, who could not be with us today. And so on page 2, we have the education and capacity building summary, which summarizes our top training that we provide at New York City Health and Hospitals and the type of modality and the number of completions that we have achieved. For example, we've concentrated on identifying and managing unconscious biasness, sexual harassment, and other diversity and inclusion related trainings for New York City Health and Hospitals. Next, as part of our education and capacity building, we've been having sessions related to women who lead in our organization. For example, we've had a series related, in May, for example, we had the Chief Corporate Officer, Catherine Patsos, who focused on developing the growth mindset. We also had in June, our community care CEO, Nicole Jordan Martin, who focused on mobilizing minds for community transformation. And in July, we had our Chief Quality Officer, Hillary Jalon, who focused on transforming health and outcomes through collaboration and leadership. We've had a lot of participation from many of our staff, not just women, who have participated in hearing these sessions. And we will continue that. Next, we have our internship and career ladder programs that have been implemented across health and hospitals. We have a centralized internship program that provides opportunities for high school students and college students from many diverse communities. We've had high school partnerships, which include the summer youth program, and Ladders for Leaders, our college partnerships with CUNY, NYU, John Jay College, and many other colleges. Students have gained valuable experience by working with us in departments such as the Office of Population Health, Ambulatory Care, Pharmacy, and Administration. And we, as healthcare leaders, have gained valuable experience as well by mentoring these students, which could someday be our employees for tomorrow. The data reflects that the number of interns in these programs since August of 2024 to July 2025 have been 188 applicants and 65 were placed in various departments. We will continue to build on this particular program. Language access. We've had phone and video interpretations. We also look at the feedback of our users to make sure that we are satisfying our clients, and we have a 96% satisfaction rate based on over 25 million minutes of interpretation in 152 unique languages, which is amazing. Currently, we are working on several Epic integrations for 2025 that will help us further document the use of interpreters in our medical records, so that we can better understand the utilization and how we're meeting the needs of our patients.
If it may be worth just saying, how happy we are at the number of Wolof, because there was a moment when we couldn't even find a Wolof interpreter. And the fact that the system was able to, rise and come up with 20,000 calls to answer is very impressive. And we know one of the interpreters was somebody at our HERC who spoke a variety of African languages and who decided, based on his positive experience at the HERC, that he wanted to be an interpreter for us.
Nice.
Wow.
That's amazing.
Absolutely. We have a written translation RFP that has just gone live, and the new contracts will start in the year 2026. So we're getting ready for implementation of that. Next, we have the expansion of our own medical interpreter skills training program with a new cohort of applications which began in August 19th. So we've increased languages from 15 languages in training up to 20, which is amazing. We continue to expand the utilization of our own staff being trained as medical interpreters in various languages, not just Spanish, but also, as you see, Urdu, Ukrainian, Japanese, etc. And we have an initiative to continue to support our veterans and to support the veterans of New York. We continue to have veteran pop-ups that we've accomplished in several of the facilities with very good participation, and we have other facilities that have requested the same thing so that we can further expose not only our employees, but our patients and our community to share information related to veterans and what their rights are and what the opportunities are for them as employees, but also the services that they can receive for being a veteran in New York. We have, of course, a Veteran Resource Expo that's going to be coming to us at Water Street on October 22nd. We have been designated also a military-friendly place in New York City Health and Hospitals. There was a criteria that we needed to submit, and so we have now earned the pledge status through June 2026, making us as an organization a military-friendly place to work and to visit in terms of our hospitals. There are other higher designations that we will be aspiring to achieve, so we're very excited to be part of this. Our employees are excited to participate in this particular designation, so you'll hear more about that in the future. Disability awareness. We've held several, of course, panels related to deaf and hard of hearing for our patients. The last one was held on August 31st. Our panel included, of course, participants from the facility, from Bellevue, Elmhurst, Kings County. We also had the founder of American Sign Language and the Director of Language Access and Support Services. We've had 52 attendees joined and learned about some of the common challenges and best ways to help support the deaf and hard of hearing as patients. And this continues to be of particular importance to us, and we look forward to expanding our disability awareness and the strategies that we're implementing across the system. So our long-term care facilities have been very busy this year, and they have been designated, all 5 of them, in post-acute care have been recognized as the LGBTQ long-term care equality leaders by the Human Rights Campaign Foundation and SAGE. Across all participating nursing homes throughout the nation, only 11% earn the highest leader designation. And now this includes post-acute care facilities. So we congratulate them for this great achievement. And of course, the summertime has been a busy month for us as we recognize Pride Month and other festivals. All of our facilities have been participating and recognizing in their own way Pride Month, including marching in the parade and doing things locally with their patients and with their employees. And there's some pictures that are reflective of all the fun things that they were doing. We had several communications and marketing strategies that were implemented that were promoting inclusivity and accountability workshops. We had holidays and observances recognized, including the Caribbean American Heritage Month. We had the distribution of holidays and religious observances, newsletters, also related to Disability Pride Month, International Non-Binary People's Day, etc. And we had our staff participate in the National Puerto Rican Day Parade and the National Dominican Day Parades. And as you can see, Gotham was having a lot of fun with this. And they were very excited, along with our other employees, to be recognizing the community and in participating. Any questions related to this report?
Dr. Katz?
No questions. Very impressive body of work.
Jackie Rowe Adams?
No, I like this presentation because I had a disabled son, and it wasn't a language barrier, but it was muscular dystrophy and legally blind. And so I'm just glad to see that this is continuing, and the community and the patients are getting the help that they need.
Yes, it's important.
Very important. And so, what days do you operate?
In terms of the language access, it's every day because we are a 24-hour operation. We have designated what we call language coordinators at the facility. And when we think of deaf, of hearing impaired, we consider that a language in the sense that we need to provide information, and we need to provide tools to our staff and equipment to help us communicate with the patients. Hopefully before they arrive, we know that they're coming, and we're able to plan for their visit and to make sure that they have either the right deaf interpreter, language interpreter when it comes to sign language, or if they have anything that they need to be able to visually see with, or if they need to have the special, braille information, that everything is available for them before they get there. That's the ideal state that we look for.
That's wonderful because he would go to daycare center. So that's, to get all the things that you were talking about. Thank you. Keep up the good work.
Vanessa Rodriguez?
No questions, just this was a great presentation, a lot of data that you presented, and I'm looking forward to seeing, this continue and the new programs that will help not only the patients but the staff.
Absolutely, absolutely.
I have a few comments. I think it's wonderful what we're doing with the Women Who Lead sessions. Dr. Nicola Davis, you were the first, correct?
Yeah.
Yes, so I think that's wonderful that you took that lead and led on that. And I would love to actually hear, were they recorded by any chance?
I think they were.
I definitely, can somebody send a link or something?
Sure.
Okay, great. Also, the medical interpreter skills training, the increase in the number of languages, that is phenomenal because it's the staff doing it, and I think that is awesome, and that we've readily made available languages that were needed for them to learn to provide the service. I think that's awesome that we're doing that and that those numbers are increasing. The veteran-friendly journey, I'm sure we will meet the designation and we will choose others to be proud of. So I'm very proud of the work that we're doing there. And our LGBTQ plus long-term care, equality leaders, I think that's awesome. We have 5 long-term care facilities and all 5 have the designation. So I think you guys are really doing the work that needs to be done, and thank you for carrying that torch.
Great, thank you.
Thank you. Next is an update from the Equity Access Council, update by Dr. Nicola Davis and her team.
Great. Thank you so much. So today we're going to be speaking about our monitoring and evaluation subgroup of the Equity and Access Council. As you know, there are different teams within the Equity and Access Council. We have the Workplace Diversity Group, the Workplace Inclusion, the Equity of Care, and monitoring and evaluation. And today we're going to be focused on some data from our monitoring and evaluation team. We've been working to evaluate our race, ethnicity, and language data. You can go to the next slide, please. The next slide, yep. And today, for presenting this data, I've invited some of my team members who've been doing a lot of this work. So we have Carolyn Cook, who is our Director of Research Data Operations, and we have Dr. Erin Lewis, who is our Senior Director of Research and Evaluation, and they've been doing lots of this work on evaluating our race, ethnicity, and language data. So I'll turn it over to
Great.
Carolyn.
Thank you. And do you need me to?
No, we're good.
Great. So yeah, we're happy to present you with our evaluation findings on validating our system's race and ethnicity data. So just to ground us in this type of work, the Institute for Healthcare Improvement defines 4 dimensions for validating race and ethnicity and language data, which we will call real data during this presentation. And those dimensions are accuracy, completeness, timeliness, and consistency. And they're all important dimensions to consider when designing an evaluation, and we'll walk you through the various approaches that we took this last year for validating the data. As a quick recap, in 2021, Health and Hospitals made updates to the way we collect race and ethnicity data to improve consistency and completeness. This included standardizing our race and ethnicity categories, making the fields required to create more standardized reporting, and also introducing some new data collection methods. So now that we have that updated data collection system, we have the goal here to evaluate if we have complete and accurate real data across our system. So why should we validate our data? There's lots of reasons, including reporting, but mainly it's important to understand the demographics of the communities we serve and be able to identify, evaluate, and address health disparities. The first step we took in the validation work is assessing completeness. We looked at how complete our data is, if the changes that were implemented in 2021 improved our collection rates, and importantly, we felt we should first narrow down the population that we're looking at to just those who were seen for a completed clinical encounter. And we looked at completeness across different years over time. And then we also stratified our 2023 data for any differences across age or facility or service type. Great. So during this time, completeness improved. We saw about 1 million patients per year for clinical encounters, and their race and ethnicity data were very complete overall. And this held true when stratifying by those subgroups, including pediatrics and facility and service type. And we did see some modest improvements by decreased missing data from 2020 to 2023 after those 2021 data collection changes. Next dimension is concordance that we looked at. So to assess concordance, we looked at a field in EPIC called the ethnic background. And we have a screenshot of that at the bottom of the slide. And this field provides the most detailed information about how a patient identifies their background. And it's an optional multi-select field with over 200 options. So we use this field in the evaluation to look at how consistently ethnic background regions corresponded to how patients are getting grouped aggregately for race and ethnicity reporting. So it's not a field that we're using day to day. And to explore this, we coded each background into a geographical region and visualized it through a Sankey diagram. So rather than show you the full visualization, we've pulled out just a couple of snapshots. So this isn't all 200 ethnic categories here. We have the grouped regions, and we're focused on this slide on patients who were aggregated to the something else race and ethnicity category. So of those patients, you can see that some of them chose something else or were mapped to something else for their ethnic backgrounds, but others listed a lot of different types of ethnic backgrounds, with the most common ones feeding into this category as North American, Latin American, and Central and South Asian. Another visualization that we pulled is we wanted to highlight the patients that identified with backgrounds in West Asia and North Africa. We know that Health and Hospitals patients have a wide range of diverse backgrounds, and you can really see that highlighted here in this category. You can see that many of these patients were aggregated to something else based on their race and ethnicity in EPIC, not using that ethnic background. But when you take a look at that more specific field, you can see these patients are really distributed across all race and ethnicity groups. So MENA is a common acronym to describe Middle East and North African ethnic backgrounds. And while this grouping is not live in EPIC just yet, it's becoming more common to collect this distinct racial grouping. And in March 2024, the U.S. Office of Management and Budget added this category to their data collection standards. And so we're submitting a ticket to help get that category into EPIC as well. Just some key takeaways from this section: leveraging that ethnic background category can help us explore concordance, and it can provide more nuance to better understand the communities we serve. The most common groups we saw our patients listing were American, Mexican or Mexican American, Dominican, Ecuadorian, and Puerto Rican. And there were several groups that were fairly consistent, most notably patients with Latin American ethnic backgrounds were very consistently being grouped as Hispanic or Latinx, using that aggregate race ethnicity field that we use for reporting. But other regions were not captured as well by those groupings, such as the Middle East and Northern African ones that we looked at. And now I'm going to turn it over to Dr. Erin Lewis to talk about another dimension of validity.
Thank you so much, Carolyn. So thank you for the opportunity to speak today. Alongside the study that Carolyn just mentioned, there was an interest in determining how well we were capturing specific or individual patient level preferences for language, as well as self-reported identification for race and ethnicity. So to this end, we found a validated survey that was published by the Institute for Healthcare Improvement, or IHI, and we extracted 10 questions that we were going to use to collect race, ethnicity, and language data within our facilities. It was a great pleasure and an honor to work with faculty and staff across all 11 of our facilities, as well as 6 Gotham sites. Particularly, we got great assistance from our Joint Commission Health Equity and Quality leads. All together, individuals at the facilities helped us with scheduling, but they also helped us to identify sites where we could use language line where needed for patients. The survey was translated into the 13 top languages for H&H based on the data that we have from our system. And we onboarded 6 interns, trained them in survey methods, and deployed them to the facilities to actually speak with individuals in waiting rooms. And so during the time between July and October of 2024, 1,172 individuals were approached and invited to participate at acute facilities, and 357 individuals were approached at Gotham sites. Of that, 45% accepted, while 55% declined. That once we had the survey data, we used their EMPI numbers to match their records to Epic so that we could see whether what they specified in the survey as their preferences were being accurately documented in Epic. And there were 536 matched surveys, and that's the data that I'm going to share on the next slides. And so overall, that sample of 536, I would just like to highlight that these characteristics are not representative necessarily of overall H&H patient population. This speaks specifically to this convenient sample. The sample that we had was predominantly female, over 64%, and individuals tended to be in the 5th and 6th decades of life. That was over 40% of the sample. Next slide, please. And so we found in those individuals with our matching data that is 75% of the time, the race that the individual stated was their self-identified race was documented accurately in Epic. Over 87% of the time, Hispanic and Latinx distinctions were properly documented. Ethnic background, only 53%, a little over 53% was accurate, and language, 90% accurate in terms of what an individual stated was their preference and what was documented in Epic. Next slide, please. So this was an opportunity for us to highlight some of the ethnic background groups that Carolyn's study highlighted as well. And we also just wanted to show that there were some instances where individuals were very well represented in terms of their preference and what was documented in the record, but there were also many opportunities for perhaps better capturing data that were highlighted by this small sample. So in terms of race, there were 209 individuals who self-identified as Black or African American, and of that, 187 had that in their EMR record. So that's over 89%, which is wonderful. However, individuals of American Indian or Alaska Native background Of the 27 individuals who stated that that was their preferred race distinction, there were no instances where that was accurately captured in the EMR. For ethnic background, again, Latin American and Caribbean individuals, 64% of the time when that was someone's preferred ethnic background distinction, that was captured in their EMR. However, the something else group, there were 25 individuals and something else was not documented in the EMR. Where again, we did well, language was properly documented for 96% of English speakers and 91%, over 91% of Spanish speakers.
Great, we have a few just key takeaways. Health in Hospitals has improved with real data collection since those updates made in 2021. 98% of data were complete and 75% of surveyed patients had accurate race and ethnicity data in Epic to what they self-reported. Ethnic background data are very heterogeneous and they provide rich information for exploring backgrounds by region. And we plan to add that new category for MENA. And most importantly, having valid real data allows Health in Hospitals to deliver more culturally sensitive and effective programming to the communities we serve.
Great. Thank you. Did you have a comment? Okay.
No,
Thank you.
Any questions?
Any comments or questions, Dr. Katz?
It's fascinating, all the ways people think of themselves and the challenge of trying to take such a complicated and loaded concept into simple categories is, very, very hard. I wonder, and someone must know it, how consistent people are themselves at reporting themselves the same with the same survey, right? Like one issue is like, do you answer differently when you're asked differently? But I bet sometimes people answer differently based on, both who's asking and how they feel at that moment, or sort of what recent experiences are important to them, right? Because so much is how you view yourself, right? And what you feel you are at that moment. But it's fascinating.
Thank you. Jackie Road?
No questions.
Thank you.
Keep up the good work. That's what we can say. Yeah.
Vanessa Rodriguez?
I have two. One, when you noted all patients, is this patients 0 and above, or this was just surveyed on adults?
All patients, and we did look at under 18 and over 18 just to make sure it wasn't more complete in one setting and not the other. But for the survey,
Accuracy survey, we focused on
Adults.
18 and over.
Okay. I mean, I'm assuming, right, the parents would answer for the child anyway, right? And then assessing the accordance, when the category other, are they combined with the unknown category that you have? Just curious about, and then something else, and then you had a category on something else. So just wondering if the option is other, where do you place those patients?
yeah, so the ethnic background is an optional field. So we were looking at, can you go back to that slide with the, I can also follow up with you, but we do, in our aggregate reporting, we do combine something else and chose not to disclose, but we have the ability to disaggregate that as well. And I would need to look closer at this diagram to see how we did it in this specific diagram. But I'm happy
I was
to
curious
follow up.
just to see, because I know it could be a lot of patients who will click other because they may not want to answer, or if they also have an option to say something else. But it may be the same person that is other. So, if you're dividing the data, it would be good just to see how many are other or something else, or
If you're not talking about
Unknown.
chose not to disclose, then
Right.
yes, other and something else are grouped together.
Okay.
And that would be an interesting thing to look at.
Okay, and then the unknown would be just totally separate, because you also have a category of unknown. I think in the next slide, no, the next one, where it says unknown.
It's so small.
I know it's small. It's something else, and then 2 or more races, and then unknown.
Okay, then yes, we disaggregated it because we think it's more important to look at it separately.
Okay.
I just didn't want to say we disaggregated it if we didn't, but we have the ability to look at it separate and together.
Thank you.
So I think I'm looking forward to what other data we capture once we add Minna to Epic. And I thought it was very interesting that Guyanese was 7%, and that's something else. And I understand their issue because they're not typically Caribbean, they're South American, and and that made me start questioning, well, what about the people from Belize? Like how, and when Dr. Katz said it's probably how we ask the question or who's asking the question, I can almost imagine what these patients, how they're responding depending on who's actually asking the question. So I found that really interesting because we are a predominantly Caribbean neighborhood where, at least for me, in the borough of Kings, and even there, I would be interested in knowing, so did we capture the Guyanese that go to Kings County, and how did they claim themselves? This Caribbean neighborhood, and nobody's thinking about South America there. So I mean, very interesting.
Very interesting.
So thank you so much. I know it's a lot of work, and we do
Yeah.
appreciate you bringing the data forward. Thank you. Okay, any old business? Any new business? There being no further discussion, meeting adjourned. Thank you.
This meeting is no longer being recorded.